talk of this last session is on the role of endovascular techniques in genetically triggered aortic disorders. Dr. Cristian Rosu is a cardiovascular surgeon at the University of Montreal, who also trained with Dr. Coselli. So, Cristian, it's your turn.
Thank you. So I'd like to thank Ismail and the organizing committee for organizing this great meeting and giving me the opportunity to speak today. So I was asked to speak on a subject that can be a little controversial, and is there an endovascular approach? Is it appropriate in patients with genetic aortopathy? I have no disclosures other than to say that I tend to try and do endovascular procedures when there are no contraindications over open procedures, but these are a special category of patients. And one of the things we need to understand about endovascular aortic repair is that we need healthy, normal aorta proximally and distally, well, in the iliacs in certain categories, but basically we need normal caliber, parallel-walled, healthy aorta in order to achieve aneurysm exclusion endovascularly. And in patients with genetic aortopathy, by definition, it's not healthy aorta. So traditionally, there's been a concern about the impact of the persistent outward force of these stent grafts, which are self-expanding, on the abnormal and weakened aortic wall of these patients with connective tissue disorders. And essentially, every manufacturer-led study has excluded these patients from treatment. In addition, these patients are usually quite young, and the very long-term results of EVAR, TEVAR are generally unknown, even in patients without genetic aortopathy. So in most situations, the application of endovascular aortic repair in patients with genetic aortopathy has been avoided. There's a few series of patients with generally Marfan that have been treated with endovascular aortic repair. The largest of these is a series of 16 patients coming from the University of Florida in Gainesville, which treated 16 Marfan patients, all who've had previous open aortic repair with a mean of 1.9 previous surgeries, some as many as 5 previous open surgeries, and all were judged poor candidates for open surgery or at high risk of complications and death with open surgery. So a total of 18 TEVAR and 1 EVAR procedures were performed in these patients. The indications in the majority of patients were chronic dissection with aneurysmal degeneration. There were 2 that had acute dissection that were treated, one with a pseudoaneurysm, one with true aneurysm, and one with anastomotic disruption. Of these 16 patients, only 6 had successful therapy and required no subsequent interventions. And that's only at a mean follow-up of 6.8 months, going out to about almost 3 years. It's fairly limited follow-up in these patients who are usually quite young. 7 had primary treatment failures, which were defined as, which were essentially hypertensive rupture on postoperative day 2 in one patient due to a type 1 endoleak and a large type 2 endoleak. This patient had open repair and succumbed postoperatively. 5 required open reintervention. 1 had coil embolization of a type 2 endoleak, which is still a reintervention, but you can say less significant. And then 1 patient was lost to follow-up and presented in cardiac arrest 4 months later, which we can presume is from an aortic cause. And note that all 7 of these patients were chronic dissections. Their conclusion was that they continue to offer endovascular therapy only to those patients who they feel have poor or no open options, and those that they believe would not survive an open operation. Another series specifically of patients with type B dissection with Marfan syndrome looked at the midterm outcomes, and they looked at aortic remodeling. 10 patients with diagnosis of Marfan based on GENT criteria and without specific genetic testing, and chronic Stanford type B dissection that were either complicated by aortic rupture, malperfusion, or acute aortic expansion were treated with TEVAR. 90% were documented as being at high risk for open surgery, and that's thus why endovascular repair was chosen as the surgical treatment. 5 had previous ascending aorta or root replacement, and 4 went on to later need ascending aorta and root replacement. All patients had successful deployment of the stent graft. 90% had clinical success that they defined as exclusion of the target vascular segment without any additional endovascular or surgical intervention. And in-hospital mortality was still 10%, which in acute aortic syndromes is respectable. But 1 patient had persistent pain and refractory hypertension, died of an aortic rupture 5 days after TEVAR during attempted open surgical repair. As far as complications go, there was also no paraplegia or paraparesis in these patients. The cumulative mortality was 20%, and then late mortality was an additional 11%. 4 patients out of the 9 survivors had an endoleak, either type 1 or type 2, and 3 patients required reintervention for an endoleak. However, no patient required open surgical conversion. But again, it's a follow-up that's not particularly long, only a mean of about 6 years. As far as looking at the total literature on type B dissection in Marfan patients and endovascular repair, there's still a paucity of data. Only 12 studies were found, identifying a total of 54 patients in this review by the University of Pennsylvania group. Indications for TEVAR in these patients were frequently either acute dissection or, in the remaining patients, chronic dissection. The vast majority had already undergone 1 open cardiovascular surgical procedure, and stent grafting was performed in a urgent or emergency setting in all patients with acute dissection and 21% of patients with chronic dissection. So looking at all comers, the rate of death was fairly low. No aorta-related deaths, a fairly low rate of surgical conversion and paraparesis, as well as low rate of stroke and renal failure. However, on follow-up, which again, with a very limited follow-up in these patients of only 30 months, the rate of death was 12%, most frequently due to aortic-related causes. 14% of these patients required surgical conversion, and another 16 had a new endovascular procedure. Looking at endoleaks, there's a 16% rate of endoleak, the majority being type 1, which is the most concerning. One other study coming from the GENTAC registry of genetically triggered aortopathy patients, they looked at over 3,700 patients enrolled in a span of almost 10 years, and TEVAR was performed very sparingly. They only identified 31 cases, majority of being male with a median age of 47. The indication for TEVAR was to repair the dissected, basically as a frozen elephant trunk type repair due to type A aortic dissection in 9 cases, and then 22 patients had TEVAR as a treatment for type B dissection. The majority were Marfan patients, although a few had other genetic aortopathies, and then the majority had, at the time, not been tested but were suspected to have a genetic aortopathy due to their early age of onset of dissection. In the type A dissection cases where TEVAR was employed as a frozen elephant trunk, these patients also had additional hemi-arch or full arch repair. And then 4 were performed in chronic aneurysmal degeneration of the dissected descending aorta after the type A repair. In the type B cases, 12 had TEVAR in the acute phase, and then 10 had their procedures in the chronic phase. There were no perioperative deaths, but 2 patients had a previous open descending replacement, which can serve as an adequate landing zone in these patients. And then I'll come to the importance of having Dacron landing zones to employ. So these are the patients who had TEVAR subsequent to or in the context of a acute type A repair. 3 of the 9 patients required reintervention, all with stent graft explantation and open thoracoabdominal repair. In the type B cohort that was treated with TEVAR, there were 9 reinterventions, the majority being stent graft explantation and open distal aortic repair, with a small minority being treated by endovascular reintervention. So overall, 13 of the patients required some sort of form of reintervention at a median of 7 months, which is very early. 3 of the patients who had acute type B treated by TEVAR developed retrograde ascending aortic dissection, which is a catastrophic complication, and 7 required open thoracoabdominal repair. So their recommendations were that patients with genetically triggered descending thoracic aortic dissection that were treated with thoracic endovascular aortic repair have a high risk of retrograde aortic dissection and reintervention, and that this therapy should be used sparingly in only highly selected situations. When you look at the guidelines, and we have a number to choose from, some being less recent than others, there's relatively little statements specifically concerning use of endovascular repair in connective tissue disorders. From the European Society of Vascular Surgery, they give a 2B recommendation to the use of endovascular repair in patients with connective tissue disorders in redo operations or in emergencies as bridging procedures. And our Canadian guidelines suggest that open repair is considered the first option in patients with known genetic aortopathy undergoing elective surgery, but in patients who do not have suitable landing zones for endovascular techniques. The European Society of Cardiology guidelines state that there's no evidence supporting any use of TEVAR in patients with connective tissue disease except in emergency situations in order to stabilize them as a bridge to eventual definitive open repair. Unfortunately, I don't have nearly as many examples as Moral does, but this is one patient we treated during my fellowship in Portland, Oregon, where we did employ TEVAR to treat a patient with Loeys-Dietz. He was a 38-year-old male with Loeys-Dietz syndrome, history of left pneumothorax in 2013, and you'll see very soon why that's pertinent. He'd had a David 5 procedure in 2003 at Stanford for a root aneurysm and had been followed with TTE. His root repair was intact. And then in April 2017, he presented to HSU with an acute uncomplicated Stanford type B, DeBakey 3B dissection essentially extending from the proximal descending down into both common iliacs. And he was treated medically at the time, and then 5 months later, he presents with some back pain, which was actually seemed to be more related to spinal disc problems, but we did note that he had greater than 10 millimeters of growth versus his previous CT scan. So he had an extent 2 thoracoabdominal aneurysm with a maximum diameter of 53 millimeters. So both of these elements pushed us to perform open repair, pushed us to perform surgical repair. However, there's quite a bit of concern about this. This is not a pneumothorax, it's actually a enormous bulla. So there's concern from the cardiac surgery team, the vascular surgery team, and then in consultation with the thoracic team, there's quite a bit of concern related to this and its implications for open repair. So we decided to perform a complex endovascular repair, which consists, I'll show you the CT scan initially. So his dissection extends from basically the left subclavian with a large entry tear, actually 2 large entry tears in the descending, down through the visceral segment with 2 important kinks, and then extending into both common iliacs. And then coronal view, just to give you a better idea of the significant kinks. So as a stage 1, we performed a right to left carotid bypass, left carotid subclavian bypass, and basically we utilized the existing landing zone in the ascending aorta, which is Dacron, and basically quote unquote healthy aorta that will not dilate. And doing a debranching by sternotomy was not particularly interesting either, because that large bulla was also stuck to the back of the sternum. So we were concerned about getting into that during reopening. So we did a snorkel from the innominate artery using a covered stent graft, a Viabahn, into the ascending graft, and then a TEVAR to cover from the ascending graft down into the distal descending below those large entry tears. We actually had to add a palma stent in the distal arch. It's a little difficult to appreciate from the CT scan, but he had a bit of a Gothic arch, and we actually found that we had compression in the. So you can see the palmas here. It was the stent graft was quite compressed with a very small lumen, so we added a balloon expandable stent here to open it up, and then we have the snorkel going up into the innominate, and you have the carotid subclavian bypass. Here's just a still image to give you a better idea of what it looks like. And then a few days later, we performed our second stage, basically construction of a distal landing zone with an aortobiliac graft using an infrarenal clamp, which is somewhat less morbid than a supraceliac clamp. We sewed to the distal common iliac artery bifurcation bilaterally, and then we performed a bypass to a pair of lumbar arteries to help preserve spinal cord perfusion, as well as retrograde debranching to the hepatic artery, the SMA, and bilateral renals using 2 bifurcated grafts, anastomosed to the aortobiliac graft. And then in the same setting, all this was performed in a hybrid room, we bridged from the TEVAR in the descending down into the proximal aortobiliac graft. So it goes by a little quickly. So that's the graft in the descending, and then the TEVAR extending down into the Dacron landing zone, and unfortunately I wasn't able to do a 3D reconstruction, but we have patent grafts to the visceral vessels. He had a bit of a laborious hospital stay after this part of the procedure, but recovered and went home. So open surgery remains the mainstay of therapy for irritable aortic disorders, but there is a role, albeit limited, for endovascular therapy. Ideally, you want stent grafts in Dacron landing zones in these patients, because you never know, even if the aorta is not dissected, it's not healthy aorta, and just the effect of the stent graft itself can lead to issues. In emergency situations, endografts may be of use as a life-saving measure, or other situations where open surgery is at higher prohibitive risk, knowing that the risk of complications and reoperation is significant. Thank you.
Great talk, Cristian. Thanks very much. 2 questions, and the scan went by a little fast, but is there an endoleak at the top remaining?
There was a type 2 endoleak that we
do you think
plugged.
it's from the snorkel, or where do you think it was coming from?
No, it was from the subclavian stump.
It's from the subclavian?
Yeah.
From the stump, okay.
Yeah.
We have, certainly in the stable patient, you can argue that this is a terrible idea. But oftentimes it's a patient presenting with rupture or something catastrophic. In that situation with an acute type B dissection, do you think in that particular scenario we should be stabilizing them with a stent and then following or getting them to a center where they can be considered for open repair?
I think it's in most centers that are not used to performing open descending repair, especially in acute type B dissection, which is open repair for that in most centers across North America and probably the world is fairly limited. So I think in that type of patient, it's reasonable to sort of get them out of the woods and then deal with reinterventions or distal degeneration later in a center of excellence that's more used to this type of surgery. The immediate outcomes with TEVAR in these patients is actually quite good, in considering the context in which it's been used. But obviously in the long term, it's not the best idea. And in elective situations, like you said, it's a pretty terrible plan for most patients.
But for an emergency, it may be just to get them out.
Yeah.
We had a young woman who was pregnant, 38 weeks, and with Marfan, and in a smaller center who had an acute type B dissection and ruptured. They did an emergency C-section, got the baby out, put a TEVAR in. She lived, I did open thoracoabdominal repair on her a couple years ago for expanding lower aneurysm, but they saved her life, and she did well for many years. So I think in the emergency situation, it may be the way to go.
Yeah, I agree.
I congratulate Cristian for his nice presentation and the limitations of this procedure. I think with my experience of more than 300 cases of acute dissection of the type B, repaired with the left heart bypass, I can tell you that it's a very safe operation with about 6% mortality rate and 3% of paraplegia. We have to remember that the best way to anchor a graft is to get a good suture line and the adventitia all around it, which is not a basic principle, which is not respected with the stent graft. Very good presentation.
Thank you.